Thank you, Michael, and welcome everyone. I'm so glad that you are all here. This workshop has been some time in the making. We're really glad, Kathleen and I are glad that everyone's here. I'm going to provide just a few overview comments, just so you kind of get a sense of what our next 2 days are going to cover. As Michael mentioned, we're talking today about cancer control in low resource areas, and our focus on the workshop today specifically is on prevention and early detection. Over the past 30 to 40 years, there have been tremendous advances in research and technology that have resulted in improved cancer care along the full cancer continuum. These improvements have led to a dramatic increase in the number of people who survive cancer and improvement in the quality of life for survivors. Improved therapies are more effective, better screening technologies help us detect cancers early when they are more treatable, and we are better able to address risk factors to prevent cancer from happening in the first place. However, there are persistent disparities in access to these improvements. The current reality, both globally and within the United States, is that many people don't have equal opportunity to the best quality cancer care. So this is the first of a series of 2 workshops on cancer care in low resource settings. In the next 2 days, we will address prevention and early detection. One of the main determinants of disparities in cancer is the country per capita income, as shown by this graph. These differences can be largely explained by the resources available in the healthcare system. Much of the global variation in survival is likely to be attributable to differences in access to diagnostic and treatment services and lack of investment in health resources. Variation in survival is associated with national wealth, including gross domestic product, total national expenditure on health, and the level of investment in health technologies such as screening, diagnostic, and treatment technologies. International differences in survival echo differences in survival within a given country between rich and poor, or insured and underinsured patients. Survival also varies widely between countries of low and middle income. There's also differences in funding invested in research and care in low and middle income countries. The amount of funding for prevention and treatment of cancer in low and middle income countries are far outstripped by the funds available for infectious diseases like HIV, AIDS, malaria, and TB. Yet 70% of cancer deaths occur in low and middle income countries, and 30% of those can be prevented. Now, we're not just here to talk about global variation, we're also here to talk about variations in resources within the United States. Not all of the differences occur globally. For example, substantial geographic disparities in cervical cancer death rates exist when you break up national data by county, despite the fact that nearly all cervical cancers can be successfully treated if they're caught early, and all can be prevented. So why do we see many of these disparities? Disparities in outcomes really are often a reflection of disparities in access to services. There are significant differences in the availability of health services. Urban areas have better access to health care and better quality care than most rural areas. And even within most urban environments, there are areas with shortages of health professionals, hospitals, and clinics. These shortages often occur in high poverty areas. This lack of access reflects demographic and socioeconomic characteristics of neighborhoods, such as poverty, lack of education, and cultural and language barriers. And they result in lower access to screening services, less access to recent advances in cancer diagnosis and treatment, and barriers to access, such as poor insurance coverage. As I mentioned, 30% of cancer deaths globally are due to leading preventable risk factors like obesity, lack of physical activity, tobacco use, and alcohol use. It is far easier and more effective to prevent cancer than to treat it. Tobacco use in particular is the most important risk factors, and it causes a large proportion of cancer deaths. And cancer-causing viral infections is another area where a lot of improvements can be made with proper use of vaccines and early detection. Now, focusing a little bit on tobacco, as I mentioned, it's the cause of the most preventable cancer deaths, and in many countries, the leading cause of cancer death. And however, we have evidence-based tools that can lead to lower use of tobacco, but they're not used and they're not applied consistently in low and middle-income countries. For example, we know that tax and price increases reduce tobacco consumption, bans on tobacco advertising, promotion, and sponsorship are also effective, and supply reduction measures such as combating the illicit trade in tobacco products. These strategies have not been implemented consistently across settings, and cigarettes have become more affordable in many low and middle income countries. We're going to hear more about tobacco later. We also see significant disparities in tobacco use within the United States, as you can see from this map. And there's substantial differences in smoking prevalence globally as well. There it is. I also mentioned infectious diseases. So a majority of cervical cancer cases could be prevented by vaccination, as we talk about very early prevention. HPV is the cause of 610,000 cervical, anogenital, and oropharyngeal cancers annually. 2 HPV vaccines protect against the HPV types that cause over 70% of all cervical cancers and the majority of other cancers that are caused by HPV. And we're still very early in the process of ensuring that HPV vaccines are available and implemented consistently across the globe. Moving from early detection to screening, about 80% of cancers in low-income countries present at a stage when cures are available, when cures are impossible and palliation is the only possible treatment available. And yet a lot of these can be detected early through organized screening programs. Within the United States, we also see significant differences in the use of cancer screening services. So for example, just in colorectal cancer tests, there's significant differences across states, and then even if you dial down at the county level, we continue to see huge variation in the use of colorectal cancer tests, which is echoed by when you look at cervical cancer screening and mammography use as well. All of this underlies the fact that population-based cancer prevention can be cost-effective, right? So it's not just about health, it's also about savings. A substantial part of the cost of cancer can be averted by investing in cancer prevention, early detection, and treatment. Cost-effective strategies to address common cancer risk factors such as tobacco use, alcohol abuse, unhealthy diet, and physical activity in low and middle income countries could cost only $2 billion per year, which is a relatively small amount compared to the costs incurred by the total disease burden. In general, cancer prevention is far more cost effective than is treatment. So the Institute of Medicine has made a substantial investment in addressing the kinds of topics that we're going to be talking about today across a number of areas. That we have the opportunity to use these foundational materials to think through how we apply these concepts to cancer prevention. So as Michael mentioned, we're here as the first part of the workshop, which will be a series of 2. Today we're going to be talking about cancer prevention and early detection. About a year from now, we're going to be here again to talk about cancer treatment and survivorship issues. Really our thinking as part of the planning committee was to address a number of issues. First, it's to really talk about how we can use the opportunities of successes happening globally as well as domestically to do some cross-innovation and cross-pollination of concepts. So we're going to have the workshop agenda. I'll give you a quick walkthrough. First, we're going to hear about an overview of global trends in cancer prevention. Unfortunately, due to a family emergency, Ben Anderson could not attend today. We're going to have Lisa Stevens, who we are so grateful could attend and pinch hit for us at the last minute. Our first session is going to be talking about challenges and opportunities in prevention, control, and early detection. There it is. Our second session is going to be talking about social cultural considerations. Then we're going to talk about cancer prevention, tobacco control. Then we have a session on addressing other risk factors and emerging issues. And then the fifth session is on screening and early detection. The last session is going to be provide a stakeholder perspectives, and will be a moderated panel, and then I'll provide a brief wrap-up. I want to thank everyone who is on the planning committee with me, and Kathleen in particular for helping me co-chair. So thank you and welcome, and we're really looking forward to your participation in the next 2 days.